specimen, and the cores were well fixed. All the cores were submitted for histopathological examination. So on imaging, these are the high magnification images of HE stained sections from the core biopsies. We can see that there is a proliferation in a sheet-like pattern of atypical lymphoid cells, which is also infiltrating into or around the intranodal or perinodal sinus, adipose tissue. So it is a kind of a very high-grade aggressive lesion. If we compare the cell size, these are the atypical monomorphous large lymphoid cells. The nucleus of a cell, if compared with a normal resting lymphocyte, appears to be 2 to 3 times the size of a normal resting lymphocyte. It has a very open chromatin and it has a central eosinophilic placed nucleolus in it. So we could say that we are dealing with a rapidly proliferative lymphoid lesion. Brisk mitotic activity was also seen, and a provisional diagnosis on HE was made with lymphoproliferative disorder, possibly high-grade non-Hodgkin lymphoma. A differential of Hodgkin lymphoma was also kept in this, but it was ruled out because we did not see any Reed-Sternberg-like cells or a polymorphous inflammatory eosinophilic rich background in the TrueCut biopsy. We proceeded with immunohistochemistry. On immunohistochemistry, the lesional cells were positive for CD20, which is a B cell marker. The cells were also positive for BCL6 and MUM1. The cells were negative for CD5, which represents the T cell origin of the cells. Most importantly, the cells were negative for CD10, which is a germinal center marker. The cells were positive for c-MYC. 90% positivity was seen, and it was a very highly proliferative lesion because Ki67 index was almost in the range of 90 to 95%. So for classification, we use the Hans algorithm. In the Hans algorithm, these are the 3 key markers which are used. If a marker is CD10 positive, which is a germinal center marker, it is directly labeled as germinal center B type of lymphoma. But if it is CD10 negative, we proceed with another germinal B cell marker, which is BCL6. If it is positive, then we do apply MUM1 because we want to see what is the post-germinal status of the cell. So MUM1 comes into the role, and when a tumor cell or a lesional cell is CD10 negative, BCL6 positive and MUM1 positive, we label it as non-germinal center or activated B cell type of diffuse large B cell lymphoma. Molecular investigations were also performed. FISH was performed to see for gene rearrangements. These are the 3 key gene rearrangements which were performed: BCL6, BCL2 and c-MYC, and all came out to be negative. So we had a final histopathological diagnosis of diffuse large B cell lymphoma, non-germinal activated B cell immunophenotype. Thank you. Now I call upon Dr. Sapna to take the discussion ahead.
Thank you, Dr. Praveena. To summarize, 80-year-old female with multiple comorbidities presented with right axillary lymph node and weight loss, and her core biopsy suggestive of diffuse large B cell lymphoma, non-GCB ABC phenotype. Now, how we will proceed with this patient? We have a tissue diagnosis of diffused B cell lymphoma. Now, what is next? So then now we have to do, number 1 is the staging. We have to see the staging of the disease. So for the staging, we have to do PET CT scan and bone marrow aspiration and biopsy. The other thing is, as patient is elderly, she is elderly patient of 80-year-old female, we have to do the geriatric assessment, that will she be able to tolerate the therapy and can we start the treatment of this patient. For the PET CT report, she underwent the PET scan. For this, I would like to call upon Dr. Sahil to tell the findings.
Why bone marrow? Is it going to change the plan of management, whether it is positive or negative? Because it's an invasive investigation.
Yes, sir. Sir, bone marrow is done to label the staging, because if in PET scan there is no uptake in bone marrow, so if there is disease in bone marrow, so we can label it stage 4.
Will it change the management?
So it will change as the staging will increase. so it will change accordingly. So, if there is only one single lymph node and we do the bone marrow and it is the disease involvement is there, so it will directly go to stage 4. So in stage 1 we will only give the chemotherapy, disease evaluate, and give only 4 cycles of chemotherapy or the radiation, and in stage 4 we will give the 6 cycles. So the disease plan also changes.
Will you do a bone marrow even if PET doesn't show a disease?
If
PET is negative except for the axillary area, will you still do a bone marrow?
yes sir, bone marrow is done because PET.
So sometimes when patients of high-grade lymphomas, they have a recurrence of the disease, and when you are considering autologous transplant as one of the options, then you don't want to infuse cancer cell containing bone marrow. So the connotation for a patient who has a bone marrow positivity at diagnosis is sometimes important and sometimes different.
And in addition, we want to see the cellularity of the marrow for further treatment.
Thank you, Dr. Sapna. Good morning, dignitaries, respected faculty members, and my dear colleagues. I am Dr. Sahil M Kalavadia, resident from Department of Nuclear Medicine. This patient was referred to us for baseline evaluation and disease staging. This is the MIP, or the maximum intensity projection image of 18F FDG whole body PET CT scan of this patient, which is clearly showing normal physiological uptake in the brain parenchyma, myocardium, liver, bowel loops, and accumulation of the radiotracer excited in the urinary bladder. Along with that, we can see there is an abnormal uptake in the right axillary and mediastinal regions, along with the focal uptake in the spleen. Now coming on to the axial sections of the fused PET CT and CT images, there was an FDG avid multiple enlarged and confluent lymph nodes in the right axillary as well as the mediastinal region, and few hypodense FDG avid foci in the spleen. Now to summarize it, there were 2 separate groups of enlarged FDG avid lymph nodes above the diaphragm, along with the 2 hypodense splenic lesions, which according to the Lugano classification falls under stage 3. As in stage 3, there are lymph nodes above the diaphragm as well as splenic lesions. And Lugano classification are a set of guidelines for lymphoma staging and treatment response assessment. Now I would like to call Dr.
Now after this staging, there is one thing left, is the geriatric assessment. So for the screening of geriatric assessment, we use G8 questionnaire, and for this patient it was total score of 10 used from the shown table. We have used this G8 questionnaire. So score of 8 means it is less than 10. That means the patient has to undergo a full geriatric evaluation before deciding to start the treatment or not. So I would like to call upon Dr. Sunil for the full geriatric assessment.
Thank you, Dr. Sapna. Good morning, respected Emeritus Chairperson Sir, VC Sir, Pro VC Sir, esteemed faculty member, dear colleague and resident. I am Dr. Sunil. In next few minutes, we will discuss about the role of geriatric assessment in oncology patients. As we all manage geriatric patients, and we know that we face multiple challenges, especially in the diagnosis and management, and we see because of atypical presentation, because they lack the common symptoms like fever, lymphadenopathy, etc., and they can simply present with the fatigue, confusion and altered behavior, and sometimes they present with the fall only, and that can be easily attributed to underlying multiple medication, comorbidities, frailty status and impaired functionality, and can obscure the underlying diagnosis like lymphoma or malignancy. And they also face ageism and have very limited access to specialized care that can delay the diagnosis. And if we talk about the aging specific challenges, that can be due to altered or slowed metabolism, which can be due to underlying hepatic, renal or bone marrow reserve, and it can lead to increased chemotoxicity risk and cardiotoxicity. We also see increased prevalence of sarcopenia in these patients, and whenever these patients get chemotherapy, the sarcopenia prevalence increases and chances increases, it can reduce the mobility and functional status, which is in itself a poor prognostic marker in oncology patients. To overcome these challenges, we have to take a systematic approach using comprehensive geriatric assessment, which is a diagnostic and treatment process for the frail older patients to identify the medical, psychosocial and functional limitation of the patient, so that we can develop a coordinated care plan and maximize the patient's overall health. To support this, there are multiple evidences and multiple studies and systematic reviews at meta-analysis has been done and concluded that it can predict overall survival, mortality, toxicity risk and treatment tolerance. They have also found that it can reduce the healthcare utilization and recommended that geriatric assessment should be systematically introduced before treatment decision. It can also benefit in cancer treatment decision, give better pain control, can detect the hidden problems in the initial evaluation and improve overall mental health and well-being. With this introduction, patient was referred to us for comprehensive geriatric assessment with the primary diagnosis of DLBCL with stage 3B, ECOG performance status 1 with curative intent to improve the quality of life. And in geriatric assessment, we have assessed all the domains of geriatrics using multiple validated tools and found that patients' non-cancer life expectancy using Lay index was 14.3 years, which is too high compared to the prognosis in the case of DLBCL. And chemotoxicity risk using cancer and aging reserve group score was 7, which is in intermediate category for grade 3 and 4. Similarly, we have assessed multiple other domains and concluded that this patient is physically fit, cognitively intact, 80-year-old female, and recommended that patient can undergo chemotherapy, and with no major geriatric assessment based intervention was required. With this, patient was referred back to medical oncology. For that, I would like to call Dr. Sapna carry forward. Thank you. Jai Hind, Jai Bharat.
Fine. Now the final diagnosis is 80-year-old female with multiple comorbidities is diagnosed with DLBCL non-GCB type stage 3 with the comprehensive geriatric assessment showing fit for reduced intensity chemotherapy. This case was further discussed in multidisciplinary tumor board and was discussed seeing her age, the diagnosis, staging and the comprehensive assessment scoring. So she was planned for tailored treatment in form of R-mini CHOP with interim disease assessment with PET scan post third cycle. Also, all the patient has been treated according to NCCN guideline. So in NCCN guideline, it also suggests that in elderly patient we can use R-mini CHOP. And what is R-mini CHOP? It composed of rituximab, cyclophosphamide, doxorubicin, vincristine, prednisolone with the reduced doses than standard. As we can see in this table, it has a at most of 50% reduced dose. So after the cardiac clearance and PICC line placement, she was started on R-mini CHOP 3 weekly with prophylactic PEG GCSF. In further course, she was evaluated clinically before each cycle, and she had a good response. She had a systemic improvement. The axillary lymph node decreased in size. She had improvement in appetite, and she gained weight of 3 kg. She also tolerated each cycle very well with the minor toxicities. She had hair fall, but she had hair fall and have few grade 1 toxicities like neutropenia, peripheral neuropathy, nausea and fatigue. After 3 cycles, the interim PET scan suggestive of optimal response. Therefore, the same treatment was continued in the form of R-mini CHOP. After 6 cycles, there was clinical progression with the increase in size of axillary lymph node, and repeat PET CT was advised. I would like to call upon Dr. Sahil to discuss the interim PET scan and the post 6 cycle PET scan.
Thank you, Dr. Sapna. So this patient was subsequently sent to us for 18F FDG whole body PET scans post 3 cycles and post 6 cycles for treatment response assessment and evaluation. Sorry. Now these are the MIP images for the baseline. On the left side we have the baseline PET CT scan, while on the right side we have the post 3 cycles of chemotherapy scan. We can clearly see there was significant reduction in FDG uptake in right axillary as well as the mediastinal region, also in the splenic region. On post 6 cycles of chemotherapy scan, there was a reappearance of the FDG uptake in the right axillary region, while there was no such reappearance in the mediastinal or as well as in the splenic region. Coming on to the axial sections of the fused PET CT images, corresponding to the results we show on the MIP images, we can clearly see there was resolution of most of the previously seen lymph nodes in the right axillary region as well as the mediastinal regions, and also in this hypodense FDG splenic lesions were also resolved. But on the post 6 cycles chemotherapy scan, there was a reappearance of the FDG avid right axillary lymph node, while the mediastinal lymph nodes and the splenic lesions were remained silent. Now to summarize it, post 6 cycles of chemotherapy scan, the scan was suggestive of low grade residual active and inactive lymphomatous etiology. Now in lymphoma cases, we have 5-point scoring system, dual score for treatment response assessment, and according to that score, we gave dual score 4 because the SUmax of right axillary lymph node was moderately higher than that of the liver. Thank you. Now I would like to call Dr. Sapna to take the case forward.
What, is it residual or recurrent? Because it had disappeared at 3 months.
No, sir.
And then it has come back again.
No, sir. There was in the post 3 cycles of chemotherapy scan, there was low grade FDG avid, sir. It didn't go like completely resolve that lymph node. The size was significantly reduced, and the FDG uptake also was significantly reduced, but it did not resolve completely. Like we can see.
Good morning, respected dignitaries, respected teachers, and all present. I am Dr. Kanupriya, second year DM resident from the Department of Medical Oncology. I'll be taking the case further. So now till now we know that the patient has progressed post 6 cycles of R mini CHOP. Now this was confirmed radiologically, but for pathological confirmation of the diagnosis, we advised a repeat axillary lymph node biopsy. But the patient refused for the same, so we went ahead with an FNAC from the right axillary lymph node, which was suggestive of high-grade non-Hodgkin lymphoma. Now we have a case of primary refractory DLBCL since the patient has progressed on treatment. So the case was rediscussed in the multidisciplinary tumor board. Now we have two options further, either to offer best supportive care to this patient or to go ahead with further cancer-directed treatment. Now since the patient had a good performance status and looking at the geriatric assessment, she was planned for second line of targeted therapy, which included polatuzumab vedotin and rituximab, 2 agents given every 3 weekly. Now at this point of time, I would like to discuss what is polatuzumab vedotin. Now it was a newer drug which was launched in India in March 2023. It is an antibody drug conjugate which has 2 parts. Basically, one part attaches to the CD79B, which is a molecule attached on the malignant B cell surface. On the other hand, it directly transfers a toxic agent known as MMAE, monomethyl auristatin E. So on one side it directly attaches to the malignant B cell and directly transfers this toxic component into the cancer cells via the process of endocytosis, directly killing the cancer cell. So this patient was started on polatuzumab and rituximab. She was tolerating it well up till the 3rd cycle. There was significant reduction in the size of the axillary lymph node. But after the 4th cycle, there was clinical progression. Again, the size of the right axillary lymph node started to increase. We again requested a PET CT for the same. These are the 2 MIP images. This was the image which was before starting polatuzumab. The size of the lymph node, as we can see, has significantly increased post 4 cycles of this targeted therapy. Again, we discussed this case in the MDT. Again, we had 2 options. One, to offer best supportive care to this patient or go ahead with the cancer-directed treatment. Now, as per guidelines, we had 2 options to offer, both cellular therapies. one bispecific monoclonal antibodies, the other was CAR T cell therapy, as we can see the guidelines. Now, since bispecific antibodies were unavailable in India, we went ahead with CAR T cell therapy. Now, what are bispecific antibodies? They are engineered proteins that can bind to two different targets at the same time. One target is the cancer cell marker CD19 or 20, and the other one is the T cell. So it directly attracts the T cell towards the cancer cells, killing the cancer cells. Secondly, what is CAR T? CAR T is that patient's own T cells. They are genetically modified to recognize and destroy the cancer cells. This was the comparison between both the therapies. The major points were that bispecific monoclonal antibodies are not available in India, so they had to be imported. CAR T is very well available in India. Bispecific, they are given in multiple doses till disease progression, whereas CAR T is one and done. Now, further course, we had to give patient a bridging therapy which was planned in the form of involved node radiotherapy to the right axillary lymph node. Now, what is bridging therapy? When we plan for a patient for a CAR T cell, we first need to take the cells from the patient and then transfuse them back. But during this process, there is a manufacturing delay of 2 to 4 weeks. So, to stop the disease from progressing during this time, we need to give bridging therapy. Second reason was that if there is a high tumor burden before the CAR T, there is a more chances of toxicity like CRS and neurotoxicity. I would now like to call upon Dr. Shivangi to discuss the INRT therapy.
Thank you, Dr. Kanupriya. Good morning to all the dignitaries, teachers and colleagues. So, we have a 80-year-old female with refractory diffuse large B-cell lymphoma, post 2 lines of treatment. She was planned for involved node radiotherapy to the right axilla as a form of bridging therapy. We had planned for 30 degrees in 10 fractions at the rate of 300 centigrades per fraction, 5 fractions per week, using image-guided radiotherapy with daily image verifications using cone beam CTs. For this, patient was immobilized using a thermoplastic mold. She was positioned and a simulation CT was taken. On the scans obtained, we delineated the involved node and the axillary region. We planned the treatment on linear true beam accelerator using image-guided radiotherapy. 7 fields of 6 MV photons were used with daily cone beam CT verifications. Organs at risk were contoured and dose constraints were respected to limit toxicity. So, patient did receive a dose of 30 grays in 10 fractions over a span of 2 weeks. She tolerated the treatment fairly well with no major toxicities. Our daily cone beam CT verifications showed tumor regression, which correlated clinically with reduced in tumor size. I would like to call back Dr. Kanupriya to take the case forward.
Thank you, Dr. Shivangi. So now, after giving INRT, we have seen that there was a significant clinical response. So patient was planned for apheresis, there was collection of T cells, and meanwhile, till the transfusion, she was started on systemic bridging therapy with 2 agents, lenalidomide, which is an immunomodulatory drug, and acalabrutinib, which is a Bruton tyrosine kinase inhibitor. So these are the 2 images showing pre-CAR T. This is the status which was post 4 cycles of polatuzumab and rituximab, followed by complete disappearance of the lymph node post the bridging therapy. Again, the similar result can be seen in the axial sections. So now T cell collection was done at our institute in collaboration with the Department of Immunohematology and Blood Transfusion and ImmunoAct, which is the chosen T cell manufacturer. I would now like to call upon Dr. Nisha from the Department of IHBT to take the case further.
Thank you so much, Dr. Kanupriya. I am Dr. Nisha Raj. I am a resident in the Department of IHBT. And just to summarize, we have an 80-year-old female and she has been diagnosed with primary refractory diffuse large B-cell lymphoma, and she has been planned for CAR T cell therapy. So CAR T cell therapy is chimeric antigen receptor T cell therapy. Basically, the T lymphocytes of the patients are collected, and then these T lymphocytes are genetically modified to present the chimeric antigen receptors on its surface, which will later on target the cancer cells and kill the cancer cells of the patient. So this genetic modification of these cells happen with the help of viral vectors, and these viral vectors themselves are modified viruses which carry the genetic material, and they are like a transport medium, and then they pass the genetic material into the T cells, and then the T cells start producing these chimeric antigen receptors on their surface. So this whole process starts at the blood center, where specialized apheresis machines are used to collect the patient's T lymphocytes, and which is collected from their peripheral blood, and this process is known as leukapheresis. Once the procedure is complete, these cells are sent to the manufacturing facility to be genetically engineered into the CAR T cells. Now, the whole step includes apheresis, activation of the T cells, transfection, cell expansion and conservation. Now presently we are supporting up to the apheresis step, that is only the collection. The following steps, that is activation of T cells, transfection, cell expansion and conservation, are done at the manufacturing facility. So how are we doing the collection of the T lymphocytes? So we use this machine which we can appreciate in the slide. It is a Comtech machine which is multi-purpose. We can do number of procedures to this machine, like stem cell collection, granulocyte collection. And to understand how the process happens, we need to know that in our blood we have multiple cellular components like granulocytes, lymphocytes, RBCs and platelets. All these specific components have different specific gravity, and when they are passed in a centrifuge they form layers. That is, the heavier particles form the lower layer and the lighter particles form the supernatant, and that is how we are able to identify the target layer, and that is how the product gets collected. So we need central venous access of the patient, and then the machine is connected to the patient and the blood is drawn into the centrifuge, and that's how the layers are formed and product is collected. Now this is a whole chart of how the whole procedure happens. It takes about 2 to 3 weeks for the whole process to take place. That is, once the patient has been identified, the leukapheresis procedure is done. It is then transported to the manufacturing facility in a temperature controlled environment. There the T cell selection and activation happens, the lentiviral transduction happens, then there is product expansion followed by preservation, and then again it is transported back to the medical facility where the where through the IV route the CAR T cells are transfused to the patient. This takes about 20 to 21 days to happen. Now when we are doing a procedure, we should define how much product needs to be collected. So the leukapheresis starting material or the product that we are collecting needs to have at least 2 into 10 to the power 9 lymphocytes in the collected product. To make sure that we have achieved this dose, we need to collect an adequate volume, for which we have set formula, and according to that we collect the fixed volume. For this patient we have collected around 110 ml of the product. Now once the product has been collected, we need to do a quality check on that product, whether that product is adequate for the process or not. So we do the CD8 count, the CD3 count, the CD45 count and the CD4 count on this product through flow cytometry, and this is again cross checked by the manufacturing facility, whether and then only the process starts. Now the product has been collected, the quality check has been done, all the parameters are normal, then this product needs to be transported in a temperature controlled environment so that degradation and spoilage of the product doesn't happen during transportation. So specialized containers have been provided by the manufacturing facility. This packaging happens in-house once the product is collected and quality checks are complete. It includes a cardboard box covering which is followed by insulating material, dry ice, and then the product is covered with the dry ice, the box is sealed and labeled, and then it is transported, and that is how we hand over the product to the manufacturing facility to avoid spoilage. Thank you, and now I would like to invite Dr. Kanupriya for taking this case further.
So the CAR T therapy course, which took around 2 to 3 weeks, leukapheresis done at our center on 30th May 2024. The manufacturing and the expansion was done at ImmunoAct at Bombay, and finally the patient preparation and the infusion of the CAR T cells was done at Tata Memorial Hospital, Mumbai on 8th of July 2024. So post CAR T, the patient experienced few toxicities, cytokine release syndrome grade 1 on day 2, but there was no neurotoxicity seen. Neutropenia was there lasting for 6 weeks, and grade 3 anorexia, fatigue and hypogammaglobulinemia, which required 2 IVIG doses. Now post-CAR-T, we offered the prophylactic treatment to the patient, which included infection prophylaxis with antibacterials, antivirals, pneumocystis cerevisiae prophylaxis and antifungal prophylaxis. Immune support was given in the form of IVIG replacement, and revaccination was also started. Inactivated vaccines after 6 months and live vaccines after the immune system recovery at 1 year. Now the current status of the patient is that the 3-month post-CAR-T and the 12-month post-CAR-T PET-CT are showing complete metabolic response. The patient is currently 15 months post-CAR-T cell infusion. She is doing clinically well, maintaining a good quality of life. She is on regular clinical follow-up with us, and the next scan has been planned after 6 months. To make a special mention over here, she remains the oldest patient in the country to have received the CAR-T cell therapy. I would now invite Dr. Ajay Yadav, the professor in Department of Medical Oncology, for his concluding remarks.
Good morning, respected teachers, my colleagues and students. So, as we all know that the incidence of cancer increases with age. And as country, India is in a process of transformation from developing to developed country, and in this transformation it is expected that in coming decade or in next decade we will have more and more patients who will be elderly, more than 70 or more than 80-year-old. So for these patients, the message we want to convey with discussion of this case is that the only age should not be considered as the decision making factor for these elderly patients. Geriatric assessment is very crucial for these patients, and with the reduced intensity regime and targeted therapies, we can treat these patients with curative intent. In this case, targeted therapy and CAR-T cell therapy was used, which is less intensive, and the toxicity is less with this procedure. Bone marrow transplant, which has more toxicities, that was not possible in this patient. So CAR-T cell therapy is a backbone of treatment of lymphoma patients, and we can treat these patients. The special mentioning is that we have this ongoing study in our department on geriatric assessment, and more than 120 patients has been enrolled. For CAR-T cell therapy, for 2 or 3 years back, we were not able to think about it because the cost was very high. With other countries, the cost is around 4 to 5 crores, but with this Indian product, the cost has reduced significantly. Even USA and other countries can't believe that we are doing CAR-T cell therapy at only 50 lakh rupees in India. That is very important for us. So, age should not be considered as the single factor. Geriatric assessment is very important, and with this less toxic treatment we can cure the patient, and quality of life is very important for these patients, and with newer treatment options we can maintain the quality of life for these patients. As we have seen in this patient, she is disease free and her quality of life is very good. With this, I thank you patient and family. I thank you to the management of MGUMST for providing us support at all time. I am thankful to our collaborating department including hematology, oncopathology, nuclear medicine, radiation oncology, IHBT and geriatric medicine. And special thanks to the CCR committee, especially Dr. Jaiswal and Dr. Lalit Mohan sir for their support. With this, I thank you all of you for sparing time for this activity.